Welcome to our presentation showcasing a virtual simulation that we co-created with people living with bipolar disorder.
The presenters acknowledge and respect that we are situated on the traditional lands of the Anishinaabe people of Turtle Island and proudly recognize our local host, the Atuknamishning Anishinaabeg. We also recognize the contributions of the Wanapitei First Nations and the Métis Nation of Ontario.
In this presentation, we plan to outline how we hope to improve simulation-based education through person-centered simulation development with attention to equity, diversity, and inclusion. We would like to thank the Canadian Mental Health Association, Sudbury Manitoulin, and Persons with Lived Experience for your valuable partnership in this project. This project was supported by funding from the Canadian Alliance of Nurse Educators Using Simulation. The prevalence of mental health disorders has been increasing worldwide, with common reports of poor access to effective care, stigma, and discrimination in healthcare. Nursing students often feel underprepared to care for individuals with mental health conditions, and valuable mental health clinical placements are frequently limited in availability and experiences. Specifically, nursing students struggle to apply classroom content, often delivered in traditional didactic methods, to real-world practice situations. Virtual simulation is an innovative, immersive, safe, and effective tool that has been demonstrated to enhance students' knowledge, skills, and confidence. Unfortunately, there's only a limited repository of authentic, open access mental health virtual simulations. Persons with lived experience are considered experts by experience within their diagnosis or health condition. They have in-depth knowledge and a unique perspective. However, despite the increasing prevalence and impact of mental health conditions, the first-person perspective remains underrepresented in nursing curriculum and healthcare decision-making. Partnering with persons with lived experience in the development of educational tools has many benefits. For example, promotes patient-centeredness and reduces stigma, conveys an authentic picture, a person beyond a diagnosis. And it helps to bridge the gap between theory and practice by ensuring that the curriculum remains responsive to the needs of people receiving care.
Co-creation provided a space for diverse expertise to improve the relevance and authenticity of the virtual simulation. This process promoted shared decision-making and respect for the lived expertise of individuals. Of note, the partnership was ongoing from beginning to end of the process, moving beyond the traditional reviewer role to active participation in objectives, scripting, recording, and reviewing the simulation. As we show you the simulation, we highlight elements of equity, diversity, and inclusion. It is also important to acknowledge that the simulation development process itself was anchored in ethical guidelines and person-centered approaches. Starting with our needs assessment, it was informed by a scoping review and a survey of nursing students, faculty, and community partners to identify curriculum gaps in mental health care education. These findings were brought forward for discussion with people with lived experience in this project for analysis based on their perspectives and expertise. The objectives for the simulation were a result of collaborative decision-making informed by all three sources of information. For example, students, nursing faculty, and healthcare workers confirmed that there is a need to better prepare graduates to care for individuals with mental health disorders and highlighted the need for experiential learning. The themes identified in the survey informed the development of our case study, learning objectives, script, decision points, and rationales. In partnership with people with lived experience, we developed Joe's story using the CASN process and Enaxle healthcare simulation standards of best practice. The development team worked to integrate the perspectives from the needs assessment throughout the process, placing emphasis on co-creation with persons with lived experience. The simulation outlines the journey of someone living with bipolar disorder that presents to the emergency department with depressive symptoms. In the objectives, themes of stigma, patient-centered approaches, therapeutic communication, and health assessment are evident. It was really important to everyone in the room that we teach students how to approach care in a non-judgmental manner when people are living with a mental health disorder. One of the things that stood out in our discussions was how important effective communication and language choice were when talking to someone who is struggling with mental health. It was important to the team that we warn learners about the sensitive nature of the topic and also let them know that the situations they're seeing in the correct and incorrect options within each decision point were driven by real-world experiences of clients and healthcare providers. Our approach was to reach a balance in psychological safety of the learner while tackling difficult topics. A content warning was included in the simulation alongside resources for learners. Planning the simulation was time-intensive. It involved educators, people with lived experience, as well as experts from the Canadian Mental Health Association who supported those sharing their experiences. The script was driven by the co-created objectives, but there was considerable discussion about what were essential points to highlight throughout the case, from the perspective of the people with lived experience. The case summary was drawn from real-life experiences, but does not represent any one person. It is not a real story, but it is a story constructed from a number of persons' experiences. The important piece is that the specifics are not necessarily the focus, but the underlying lessons and themes are, and should be transferable to real-life clinical situations. The recording involved people with lived experience in director roles to ensure the authenticity in the portrayal of the story. It was important to have support systems present in the filming and to take breaks to avoid overwhelming the team. As the case unfolds, the virtual simulation highlights some of the stigma and stereotypes associated with mental health disorders. For example, we begin the simulation exploring the idea that it is not okay to refer to people who are struggling with mental health issues as frequent flyers. This first decision point asks what priority information the triage nurse should relate about Joe. If they select frequently seen in the ER, it is incorrect. Instead, students should be outlining depressive symptoms. At the end of the decision point, students are presented with the rationale for correct and incorrect options. Decision points, such as this one, allow students to choose the path that the case takes and learn from the consequences of their choices. Another way in which learning happens in virtual simulations is through modeling of behavior. Throughout the simulation, therapeutic and person-centered communication is modeled. In decision points, the importance of appropriate communication, content, and delivery is also reinforced. For example, learners need to figure out how they would introduce themselves to the patient. If they choose incorrect options, they're asked to try again and directed to some rationale. Rationale is also provided when they select the correct options. Health assessment skills are highlighted in several points throughout the simulation, requiring learners to prioritize within a context. For example, here students are asked to consider the information given and make a decision on which assessment should be completed first. Collaborative care planning was highlighted by people with lived experience as important in their care experiences. For example, considering what the client wants or needs prior to making a suggested plan for care. The nurse also involves appropriate community partners to support the client's wellness based on what the client says. Follow-up to ensure that the client has resources after they leave the hospital was another thing that was important for people with lived experience. Our co-creation yielded an authentic simulation that may not otherwise be achieved without the partnership with people with lived experience. The process of developing the simulation was a valuable experience for educators, sometimes highlighting implicit biases. We believe that this simulation is beneficial for promoting student reflection on caring for people living with a mental health condition, and it needs further testing. Simulations like this one have been found to be useful for starting meaningful discussions with learners and can be used in diverse ways within the curriculum, such as preparation for classes, labs, or clinical, or within the classroom environment itself. We hope that our simulation contributes to the development of well-rounded healthcare practitioners and consequently a more inclusive healthcare system. Furthermore, we hope to inspire others to co-create simulations with people with lived experience with the goal of increasing social accountability in education. The next step is usability testing, which we plan to outline in the future. After usability testing, an evaluation study is being planned to test the impact of the simulation on learning outcomes related to reducing stigma and improving person-centered communication. Thank you for listening. Here is a link to our simulation if you'd like to review it. Please reach out if you want to connect further about our project.